Bore da pawb, good morning all. As set out in A Healthier Wales, our ambition is to bring health and social care services together so that they are designed and delivered around the needs and preferences of individuals, with a much greater focus on keeping people healthy, well, and out of hospital. We want a seamless whole system approach to health and social care. Services from different providers should be seamlessly coordinated, and we should go beyond traditional service boundaries to make a difference to individuals. And clusters are the best way to achieve this.
It is well known that many people presenting with health issues do so as a consequence of an unmet need. Individuals may not need medical intervention. What they may need is support to help them stay healthy, well, and active, and to help them stay connected to their community. Evidence tells us that loneliness and isolation is one of the biggest contributing factors to people's poor health. However, often the system we work in supports us operating within our own areas of specialism. It is often difficult to know what range of support is available to help people's needs, let alone how to access them. We need to find ways that support us to work together across organizational boundaries and with our communities to find preventative solutions that will not only result in better outcomes for people, but also create better efficiency within our health and social care system. We need to find ways of stepping away from our overly specialist and separate models of care in the community, away from protracted referral processes into a space where an individual only has to tell their story once, have their needs understood, and then very quickly met by the resources that are available to them within their own community. Recently, I attended an event with Hilary Cottam, author of Radical Health. She spoke with ministers and other key stakeholders to help us to challenge our current thinking in how we provide care and support for people. Hilary advocates for a wholesale reform of the way of supporting people, starting with good relationships between people and their communities, between people who need care and support and those who support them, and between the agencies who offer support. I do recommend, if you get a chance, to have a look at her work.
As Judith mentioned at the start, both primary care and social care services have had to adapt and find new ways of working due to the pandemic. Primary care remains the front door to the health service, and so it is extremely important that it's remained open over the past 2 years. I am extremely proud of the way that primary care has responded over the last 2 years, working together to support those with the most urgent needs, adapting to the situation as it's evolved, and particularly involvement in the COVID vaccination programme. Back in 2020, we introduced the Primary Care Contracted Services Immunisation Scheme, which enabled health boards to engage all four primary care providers in the delivery of COVID vaccines. This is a UK first in terms of cross-professional contracting approach, which supports collaborative and scaled-up delivery of services. This has provided significant additional resource and capacity for vaccine delivery in Wales and assisted health boards in their planning and ability to deliver vaccines as close to home as possible. Some other examples of cluster delivery include new audiology service models to have a primary care advanced audiology practice in all health board cluster areas, where audiologists will be the first point of contact for people with hearing problems. Betsy Cadwallader University Health Board are leading the way with primary care audiology services being delivered in 9 out of their 14 clusters. And a small number of clusters, including the 3 in the Vale of Glamorgan and North Rhondda, have established urgent primary care centres to ensure their populations have access to urgent care within 8 hours of seeking help. The learning from these is vital and is feeding into the strategic programme for primary care's work on a national plan for urgent primary care.
Across our system, we need to embed a no wrong door culture, which means that wherever an individual seeks help, they will be supported to access it, even if it needs to come from another part of the system. To achieve this, we need to redesign our services, our teams, our workforce, to ensure they are enabled to work in this holistic and integrated way. I am clear that this won't just happen on its own. It will take organised effort and sustained commitment to create the right partnerships at a regional, local and cluster level to ensure seamless preventative communities become a reality. Here in Wales, we are in a strong position of having the legislation, the Social Services and Wellbeing Wales Act, the policy, A Healthier Wales, and the resources. For example, we've just recently allocated 144.6 million per annum a regional integration fund. And this puts us in a good place to take the agenda forward. Regional partnership boards have made some good progress in developing new integrated models of care. For example, the home from hospital services greatly aided us during the pandemic. However, it is recognised that stronger connections between regional partnership boards and our primary care sector is needed. This is something we are actively seeking to address in the new programme for government. While we have made some good progress in recent years, we have not yet achieved our ambitions, and we need to accelerate our progress in integrating health and social care to support the provision of seamless services. And I'd like to share a really positive example of what is possible if we use our imagination and create the right partnerships. The social prescribing agenda continues to gather pace, with most parts of Wales now having access to some form of community coordination. Much of this activity has been successfully kick-started by the Integration Fund and the Transformation Fund. We will now be seeking to work through the regional partnership boards and the new Regional Integration Fund to ensure these new ways of working become fully embedded in our health and social care system. And one particularly good example of community coordination is the Mourne Community Link social prescribing service. In Anglesey, the GP cluster group in April 2019 entered into a pooled budget arrangement alongside the council and the local health board to test an asset-based approach to social prescribing and the provision of information and advice. This project now employs 4 local asset coordinators, a triage officer, a development officer, and third sector community and wellbeing officer. And the project uses 5 ways to wellbeing to work with cohort groups, including over 50s at risk of becoming inactive, low-level mental health, lonely and isolated, and recently bereaved. The project works closely with GP surgeries, various departments, including social services, housing support, community mental health team, community resource teams, and other partners such as the North Wales Police and third sector organisations to take referrals through a social prescription platform. The local asset coordinators work on a one-to-one basis to set wellbeing goals with an individual that will help them to reconnect with their own communities and to remain healthier for longer, keeping people away from frontline services for longer. Wellbeing goals include attending activities that promote general health, such as walking groups, swimming, paddle boarding, green prescribing activities such as bushcraft, and activities that promote mental well-being, such as befriending groups, courses, men's sheds, and mother and baby groups. This project is open to individuals, adults over the age of 18 and to children and families. This project is a really great example of how we want to see a partnership-based approach to making best use of the resources we have available within our communities that will encourage individuals to think more about preventing long-term illness. Now, of course, often individual stories really bring to life the impacts of this way of working. And one example is an individual named Jenny who had a range of health issues. Jenny had fallen in her home and as a result had become withdrawn, lost confidence to go out on her own. She did not want to be a burden on her family, but needed support to help collect prescriptions or visiting the post office to pay bills. Now, the local asset coordinator worked to connect Jenny with a good turn service that assists transport and befriending. And two volunteers from the scheme offered to assist to take Jenny shopping, to assist Jenny to be able to collect her prescriptions, and to enable her to pop to the post office to pay her bills. And volunteers also visited Jenny on a weekly basis. So the Good Turn scheme also assisted by providing Jenny with a personal alarm, which gave her back confidence around the home in case of a fall. An absolutely wonderful example of a great service of bringing together volunteers and communities to support an individual. And the project is overall monitored through data, and outcome information is gathered via the social prescribing platform. This allows them to capture a range of health and well-being data on individuals they support. And the platform also enables GPs to make referrals direct from their own notes on the screen whilst with the person, as well as having a self-refer option. And this means that for all partners, the cluster is able to keep track of the whole journey of an individual, regardless of who they've been referred by and where they have been referred to. It's just one great example of the many ways in which we are now developing truly integrated, community-based interventions.
Working at scale, or cluster working, is a common priority for the reform of all primary care contracts. This includes GMS, dentistry, community pharmacy, and optometry. Service delivery at cluster level is predicated on enabling health and care professionals to work at the top of their field and to build capacity, experience, and resilience in the system, providing additional and flexible options for delivering seamless care at or close to home. The most recent GMS contract agreement mandated all GP practices to be a member of a GP collaborative, which is a group of GPs working across a cluster footprint to ensure care is better coordinated to promote the well-being of individuals and communities. Integration and collaboration is vital to transforming our health and care system to achieve the vision set out in A Healthier Wales. There is a developing maturity of pharmacy involvement in clusters across Wales, and to support increased collaborative working, the Welsh Government committed further funding in April 2021, which will continue. And we'll continue to build on the progress made in both GMS and pharmacy to seek opportunities in optometry and dental. I'd like to acknowledge today the tremendous work which Sue Morgan is leading in collaboration with the 7 Health Board Directors of Primary and Community Care through the Strategic Programme for Primary Care. Today, we're focusing on its Accelerated Cluster Development Programme. Aligned very closely is the other programme, which Alan Laurie is leading, to give us a consistent definition of key aspects of community services and a suite of frameworks to guide the planning and delivery by clusters of integrated, multi-professional models of health and care. Thank you. I hope you enjoy the rest of this event. Diolch.